This next case is of an endovascular embolization of a frontal AVM using N-butyl cyanoacrylate, or NBCA. Here we have a 70-year-old male who came to the emergency room with sudden onset severe headaches and left-sided leg weakness. He was found to have an AVM. His past medical history was significant for a hemorrhage in the right thalamus. His CT angiogram showed a left frontal AVM. Here we can see on the CT scan that there is a hemorrhage in the right thalamus and intraventricular hemorrhage. The CT angiogram shows a complex frontal AVM on the left side. At this point, based on the CT imaging, we will get an angiogram. The angiogram in turn demonstrates feeders predominantly from the anterior cerebral artery with drainage predominantly into the superior sagittal sinus. Here we can see hypertrophied anterior cerebral arteries feeding the AVM. Given the fact that there is a relatively direct and robust route to the AVM, we're going to attempt microcatheter embolization by accessing the anterior cerebral artery. Here we can see a wire in the distal ACA over which we're tracking a microcatheter. Once we have distal microcatheter access, we continue to navigate the microwire under roadmap conditions until we're approaching just proximal to the nidus. Here we can see the wire is proximally at the origin of the nidus, being fed by the large anterior cerebral artery. A micro run demonstrates filling of the AVM nidus. Here we disconnect the catheter from the flush as we prepare to use N-butyl cyanoacrylate. It is critical to flush the catheter of all blood. Typically, we flush the catheter 3 or 4 times to remove any blood product, which would cause premature polymerization of NBCA. Here we can see NBCA with tantalum being injected into the ACA pedicle and filling the nidus. We continue to inject and fill the nidus with NBCA. At this point we have no reflux, so we can continue to inject. We inject both under roadmap conditions and under the native view. Injecting with NBCA requires constant injection. One cannot stop the injection as they would with Onyx. Though we have a little bit of reflux at this point, we're going to tolerate this reflux and continue injecting. Once we have sufficient reflux, we remove the catheter and we will consider accessing a second pedicle. Typically, we like to embolize approximately 30% of an AVM per sitting if we cannot embolize it in its entirety for pre-op embolization. Once again, under awake conditions, we can see the wire accessing the distal ACA and the microcatheter being tracked over the wire. The roadmap is useful but should not be relied on entirely given the fact that the patient is awake and there is motion. The reason we do this under awake conditions is so we can do WADA testing to assess what potential deficits may exist should we embolize that pedicle. A negative WADA gives us reassurance, though not 100%, that it's safe to embolize that pedicle. Again, here we see some reflux, but we see excellent filling of the nidus. Here we can see the catheter is removed, and there's significant reduction of the AVM. At this point, the patient underwent surgical resection, and there's no evidence of residual AVM. This concludes NBCA embolization of a frontal AVM.